I see that we have a few people here, so I think it's a good time for us to get started. My name is Abena, and I'm the Outreach Program Coordinator here at the ADRC. And today I have Dr. Kirov here with me, and he will be giving the presentation on the importance of imaging in Alzheimer's disease research. Dr. Kirov is an associate professor of radiology and neurology at NYU School of Medicine, and he obtained his bachelor's degree in biology from the University of California at Irvine, and he received his PhD in neuroscience at NYU. His expertise is in imaging of neurological disorders, especially with magnetic resonance imaging and spectroscopy. And his main interests are in multiple sclerosis, traumatic brain injury, and Alzheimer's disease. And over the years, he has been awarded NIH funding to study each of these disorders with imaging. His talk today will be on imaging in Alzheimer's disease research. So with that being said, I will turn it over to Dr. Kirov.
Thank you, Mina. It's a pleasure to be here. Okay, so today I'll talk about imaging in AD. And the most basic question of all is, what is imaging? All right, so let's start with this definition. So to me, imaging means different methods of visualizing structure, metabolism, or function. And the second question that's very basic to this presentation is, what types of medical imaging are there? And to this, I decided to turn to Dr. Guru. We have questions. We often look at the internet. So I was curious to see what Guru would show. So the AI algorithm worked out this list here, which I then looked over, and some things didn't make sense. Some I had to eliminate, too general, not specific. So I ended up with these types of imaging, which I then stratified by type. And it turned out that there is just a few categories of imaging which can be looked at in the following way. Here in light blue, we have imaging techniques that use X-rays. So CT, or computed tomography. For example, this is an X-ray scan in 3 dimensions. Mammography uses X-rays. Radiography is just a general term for X-rays. Fluoroscopy, X-rays. As well as myelography. The other 3 categories that came up with single hits here, but they're more wide than this, is MRI in gray, ultrasound in yellow, and also optical or acoustic imaging, which I've colored green here. Arthrogram, I didn't know what this is. Turns out to be joint imaging, which can be done with either ultrasound, MRI, or X-rays. That's why I have colored it multiple ways. So anyway, this was just kind of I was curious to see what I find here. This is not a full list; it's just a generalization, but turns out to be very good generalization for the types of imaging there are. And other than ultrasound, all these imaging techniques can actually be plotted onto an electromagnetic spectrum because they all use electromagnetic waves, it turns out. Other than ultrasound, of course, which uses sound waves. So any other sort of imaging uses electromagnetic waves, and they can be plotted on this spectrum. Electromagnetic spectrum just shows you the wavelength, the frequency of the common types of waves that we're familiar with, of course. Radio waves, microwaves, infrared, visible light, ultraviolet, X-rays, gamma rays, these are all electromagnetic waves. And the only way they differ is by the amount of energy they hold as they travel. So gamma rays and X-rays, they are the most energetic and they can cause damage. That's why this sort of radiation is called ionizing radiation. And here you can see how these imaging categories are plotted. MRI uses radio waves, so does the EEG. EEG is electroencephalogram. Optical imaging, of course, optics, visual, has to do with visible light, visible portion of the electromagnetic spectrum. These are things such as endoscopy, optical coherence tomography for the retina imaging, or near-infrared spectroscopy, other sorts of imaging that use this sort of wavelengths. And then we go into the ionizing radiation, X-ray, CTs, and PET and SPECT scans. They use radioactive tracers, which emit gamma rays, which get caught by the scanner. So these are the in the gamma rays portion of the spectrum. So for AD imaging, which sorts of imaging is important? And it turns out it's actually those two on the opposite ends of the spectrum. The MRI on the radio wave spectrum, magnetic resonance imaging, and positron emission tomography or PET on the other side. Okay, so we'll concentrate on these two techniques today because they are the most relevant for AD. And we'll start with MRI. MRI detects signal from molecules based on their response to magnetic field. The MRI scanner generates a huge magnetic field. Then all the protons align due to this magnetic field. Then the head coil sends a wave, electromagnetic wave, which perturbs them, and then they emit signal as they relax. And this signal is the MRI signal that we then process to get the images. And MRI is great for visualizing the anatomy because it's great at looking at soft tissues, which basically means that it can differentiate internal anatomy very well. It can differentiate different types of tissues in the body. So it's used to visualize anatomy. Also, it can be used in other sorts of way to look at metabolism, microstructure, brain activity. These are things that I'll touch upon and I'll introduce you to as well. And then we have positron emission tomography or PET on the other side. It works by detecting signal from a radioactive tracer, which is injected prior to the scan. Where this tracer accumulates is recorded by the PET scanner because the tracer emits these gamma waves. In the PET is a little bit less direct. It actually doesn't detect the gamma rays, but detects the positron, a positron emission that has the name of PET, positron emission tomography. But it basically works the same way. The tracer emits a signal which is captured. And the distribution and the magnitude of this tracer, when you see it in the brain, tells you something about the brain. So give you plenty of examples for that, because now we're ready to go on to more detail about these techniques. And we'll start with MRI. Like I said, it's used in the clinic widely. The MRI actually, there was a Nobel Prize for MRI in 2003. It's a technique that really revolutionized medicine. It's part of, it's central to all branches of medicine and clinical care, especially to neurology, and mainly because it visualizes the anatomy. But also, there are different sorts of contrast that can be generated by an MRI machine after you change the settings on the software. And they're all meant to identify changes in the brain morphology. Morphology is how the brain looks, or the anatomy, to identify changes that are not normal. So, and radiologist knows what normal brain will look like, so they can identify things that are not supposed to be there, such as lesions. So we'll go quickly over different sorts of MRI contrasts, or different sorts of things you can make the MRI do to give you different information. These all can be obtained in the same scanning session. So if you start from the left, this is the basic sort of imaging, which gives you the great contrast between gray and white matter, and for identifying anatomy. The gray matter is on the outside of the brain, the white matter is inside, and it's kind of whitish here, light gray. Well, the gray matter is dark gray here. This is called the T1 weighted imaging. The name really doesn't matter, but this is used for anatomy. The second here in this row is an image which is good for identifying lesions. Lesions are spots that are not supposed to be there. The third sort of image is used for identifying spots known as edema, basically water concentration, water accumulation that's not supposed to be there. And the last image that I'm showing here is from a way to see microbleeds. So this is great for identifying really small bleedings in the brain called microbleeds or microhemorrhages. So all these sequences, all these sorts of MRI, you would get in a regular MRI session. They tell you a little bit different things. So here is an example. I don't know if you see, but there is a bright spot towards the front of the brain, which is towards the top of the slide. Bright spot there, which is best seen in this sort of image that's best for identifying lesions. The second one, the flare, you can see it very well there. That's why this sort of image is being done. You can also see it on the other sequences as well, on the other images as well. I wanted to show here that on the last sequence, the one that is sensitive to microbleeding, you can actually see even more things there. So there is microbleeds that are a little bit posterior to this lesion, which you can only hardly make out in the other sort of projection. So this is an example how MRI has different sorts of sequences that are all complementary to each other, showing abnormalities that are big, abnormalities that you would be able to see if you're a pathologist and you have a ex vivo brain in your hands and you can see it with the naked eye. This sort of abnormalities that are large enough to be seen. In the next slide, this is just magnifying the lesion for everybody to be able to better see it on the slide. And here I'll just going to introduce briefly, just going to tell you briefly that MRI can also see things that would not be visible to a pathologist looking in the lab at the ex vivo brain. MRI can also be tweaked, the settings can be tweaked to show totally different information that can tell you about things that are in the normal appearing tissue, that are microscopic, that can only be seen if the pathologist takes a microscope. So these are very powerful techniques, but the problem there is that they're supposed to be catching these very subtle changes, and this means that it's hard to tell noise from biological signal. So there's a lot of work being done right now to kind of get at this and to make these types of MRI more applicable to clinical use, because right now they're mostly used for research. And the differences that you see with these techniques are usually on the group level. You take 20 people with certain condition, 20 controls, and you average them out, and then you see some sort of difference. But on an individual level, still these techniques have some issues because there's a lot of noise, because they're trying to capture all these very microscopic changes. So these are for microscopic changes. And I'm giving here an example of just 3 techniques. There is more. First is MR spectroscopy. This is my work. This can tell you about the biochemistry of the brain by looking at levels of different metabolites. And I'll show you an example in AD later. There is, maybe you've heard of diffusion tensor imaging. Maybe you've seen it, rather these images, because they're kind of pretty. They tell you the direction of the white matter tracts. The white matter connects all the gray matter in the brain. And with this sort of imaging, you can visualize the directions, different colors, tell you the different directions of the white matter. You can see how these tracts, how they branch out. If there is issues with them, you can see it's something that you don't see on a regular MRI where all the white matter looks the same color. There's also functional MRI. This sort of MRI tracks where the neurons in the brain consume oxygen, which is a proxy of these neurons being active. So if you see a picture, for example, your posterior of your brain in your occipital cortex, those areas will get activated. These neurons will start working, which means they start taking oxygen from the blood. So there is more blood accumulating there, and you're able to image that. And you see brain activation this way. So, for example, in this image here, you can see a lot of this fire, these bright spots over there in the occipital, towards the back of the brain, because this subject here was presented with some visual stimulation, and these neurons are activating because they are processing the information. So, with functional MRI, you can study processing of information, how the brain does it. Okay, so on to PET, and I'm showing here the PET that are most relevant to AD research and clinical use, of course, as you will see. So I'm showing an example of different tracers for each of these different sorts of PETs. So the first PET that I'm showing is the one on the very left. That PET is sensitive to amyloid deposition. Amyloid is a protein that accumulates in Alzheimer's disease, and it's very useful to be able to image it. And we have a tracer. This is the radioactive substance which the patient receives. This tracer binds to amyloid. So you receive it through an IV, it travels to the brain, and it binds to its target. In this case, the target is amyloid, these protein depositions in AD which are pathological and not supposed to be there. So with the PET, you image the tracer. You don't image the amyloid, but the tracer is bound to amyloid. So in this way, you indirectly image the amyloid. So you can see how much amyloid there is in the brain, in different parts of the brain. The brighter the signal, the more amyloid. Same for the tau. Tau is another protein that is found in AD, and there are tracers for tau. They bind to tau, and they light up. You can see them on the image. I'll show you examples of that in a moment. And the third PET technique, which is relevant to AD, is called FDG PET. FDG stands for radioactive glucose. That's what it stands for. Glucose, which, sugar, which is stacked with a radioactive molecule. And it acts like regular glucose. The brain doesn't differentiate between this glucose and non-radioactive glucose. So it processes the same way it would process regular glucose. And as you know, glucose is the main energy source for the body, for the brain. So the glucose goes where there is a need for it. So in this case, glucose goes to the gray matter, to the cell, to the neurons. That's where the neuronal cell bodies are. And they use the glucose, and you can see how many neurons are there and how efficient they are in taking their glucose. This is a example of a scan that's normal. There's a lot of glucose utilization here, and you can see the kind of the bright areas that denoted there in the gray matter. The gray matter is on the kind of the outside, the white matter is on the inside. Okay, so now we transfer all this background to AD, which is what we're interested in. And here's a brief introduction. So the histological hallmarks of AD are these amyloid plaques. These are extracellular amyloid beta plaques. That means it's just protein accumulating outside of the cells. There's a cartoon of it on the right. So that's one hallmark of AD. Second hallmark of AD is these tau tangles. This is protein which is abnormally accumulating inside the neurons. So that's something that's intracellular. And you can see on the cartoon, the neurons are these spiky star-looking things, and inside are the tau tangles. Outside of that are the amyloid plaques. These two types of protein depositions are abnormal, and they define Alzheimer's disease. So they are important to image. A third hallmark of AD is neurodegeneration or neuronal loss. That means that the neurons are slowly dying. And Alzheimer's disease, looking from a clinical perspective, can be divided in the following way. Here in the bottom of the slide, you have the asymptomatic phase, where it's also called the preclinical phase, which then goes into a mild cognitive impairment or MCI phase. These are the subjective complaints, a little bit of objective symptoms as well, meaning that they can be quantified or with neuropsychological testing. And then that progresses to AD with dementia, which is where the more serious cognitive impairments come in, and they can be mild, moderate, or very advanced. So this is the clinical course of AD, and next we'll kind of connect the imaging to it. So not coincidentally, I just described the types of imaging which is sensitive to these histological hallmarks of AD. So A-beta PET is sensitive to the amyloid plaques that I talked to you about just now. The tau PET is sensitive to tau tangles, so it's just accumulations of tau inside the neurons. And then we have MRI and FDG PET, which are sensitive to neurodegeneration and neuronal loss. So with MRI, you can just see plainly that there's less brain tissue. So that's why MRI is sensitive to neuronal loss. And it's called atrophy. That means that the tissue is dying. So atrophy and neuronal loss are interchangeable terms. So you can assess this using MRI and this anatomical image that I showed you and talked about. Interestingly, FDG PET is also considered a marker of neurodegeneration because when the neurons are dysfunctional and they're not doing well, and they may already, be in the process of dying, they utilize less glucose. There is less glucose utilization by neurons that are not doing well. So FDG PET, which assesses how much of glucose there is utilized, is kind of is a marker of healthy neurons. Okay, so now we'll see how these types of imaging look like along the continuum of the clinical presentation of AD, of the clinical spectrum. So here in the asymptomatic phase, so I'm starting with tau PET. So the tau PET scan is normal or close to normal, and with time, tau starts to accumulate, and it accumulates in the temporal lobes. These are part of the brain which is on the side, and which is home to the hippocampus. Hippocampus is the memory center of the brain. All memory gets processed there, and obviously the dementia has to do with memory, and hippocampus is actually one of the first places in the brain to get impacted, and to get impacted with tau and also with atrophy. So tau accumulates there first, and it starts to accumulate a little bit in the preclinical, the asymptomatic phase, and then it ramps up during MCI, and then it really accumulates during the dementia phases in the hippocampus, and from there, it actually starts spreading physically through connections, starts spreading from the temporal lobe, from the hippocampus to the rest of the brain as the disease progresses. So that was about tau PET and AD, and how does FDG PET change with AD? We'll see here. So what I had shown you before was a normal FDG PET, and you can see it in the kind of the asymptomatic preclinical phase, but it starts to, the glucose utilization metabolism starts to fall with time, starts to decline with time, and you can see from the brightness of the image, which is kind of indicative of how much glucose utilization there is, it falls. So the neurons are not using the glucose, which means they're not really doing well. That's why FDG PET is considered the marker of neurodegeneration. Glucose utilization falls. So actually, aging, some of this is normal with aging. There's insulin resistance that takes place with aging, which means that glucose is just not utilized as efficiently when one ages. But with AD, this is really ramped up, and it becomes worse than just with normal aging. And here I'm showing how the MRI would change over time with the advent of AD. From somewhat normal MRI, you would see atrophy. So like I mentioned, atrophy is neuronal loss, is basically cell loss, death of the neurons, the cells. And that death of neurons means less brain tissue, right? So the brain tissue actually shrinks. This is atrophy, shrinkage of brain tissue. And it just happens more as you advance in the AD continuum here. It's progressive. So I say this for last for a reason. This is the amyloid PET, how that changes with AD, because in what I've shown here, it actually doesn't change. It's already abnormal before MCI. And I'll show you a temporal course of imaging later. But in fact, there's a normal scan, and then amyloid gets deposited in the gray matter. It can start up to 20 years before clinical symptoms. So amyloid deposition is a very early event. And you can see here the difference between the negative scan on the very, very left, the small image, and the positive amyloid PET scan with all the bright spots. And the image on the left shows binding only in white matter. This is actually normal. This is not something to worry about. But then when amyloid gets deposited in the gray matter, that is read as a positive amyloid scan by a radiologist. and this would be a positive amyloid PET, and it actually, once it reaches a plateau, it doesn't really change. So I've put the same image everywhere here because it reaches a plateau even before clinical symptoms start. And I'll show you a very good graph of that. But this concludes the introduction, and so we're kind of ready to look into how imaging is actually used in AD. And we'll start with the clinical use. So in the initial workup, MRI is usually ordered to exclude any other underlying brain conditions. So if the patient comes with some complaints, you want to make sure that they're not due to something else. You try to exclude things. So you order an MRI. This can show all kinds of sorts of other abnormalities. It can also show atrophy, as we just spoke. So if needed for differential diagnosis, FDG PET can be ordered to see how much of the glucose is being utilized, and like I showed the examples of. And if needed, amyloid PET can be ordered to confirm AD if there is amyloid, if the scan is amyloid positive. And I'm sure that you're also aware that there is a new therapy, relatively new. There's 2 FDA-approved drugs which lower amyloid. These are FDA-approved for the treatment of Alzheimer's disease. And they actually lower the amount of amyloid. So to assess suitability for such therapy, a PET amyloid scan needs to be done to show that there is amyloid for sure before starting therapy. For follow-up, if you're not on if you're not on medication, MRI is, can be prescribed because it's super routine, safe. There's no ionizing radiation. You can have as many as MRIs as you want to look at atrophy. But if the patient is on anti-amyloid drugs, there needs to be, for at least one drug right now, the FDA states that to monitor the efficacy of this one drug, you need follow-up amyloid PET to see if the drug has actually decreased the amount of amyloid in the brain. But for all the drugs, there needs to be an MRI every regular MRIs if one is on therapy to monitor for important side effects, because these anti-amyloid drugs can actually give some side effects that are actually significant, that need to be identified, and that needs to be stopped. So for that, an MRI needs to happen on a regular basis. Yeah, that's for the follow-up. So we are now kind of concentrating on what MRI and PET have done for AD research. And all this clinical care, that is now conventional, wasn't conventional before. So research in imaging of AD has contributed to this clinical care that I just described, which is very much a big improvement from what it was before in many ways. One is the diagnosis. The diagnosis, can now be made with a high level of certainty. Before you probably, had heard that AD can only be diagnosed post-mortem. Now you have these imaging methods that can image the hallmarks of AD, so they can tell with high certainty what the diagnosis is. Also, although you can measure levels of amyloid and tau from their levels in CSF, to get to the CSF, you need to undergo an invasive procedure called lumbar puncture, which involves a big needle that needs to go all the way to your spinal cord, and that's it's invasive, painful, has risks. So forth with imaging, this doesn't exist. For prognosis, of course, imaging can now tell you about additional risk factors, can actually tell you about what the biology in the brain. And this can be integrated with the other known risk factors, such as sex. Females are more susceptible to AD. Genetics, some genes are associated with higher risk for AD. Lifestyle, of course, some forms of lifestyle and environment are also associated with AD. And now imaging can also help the clinician in further assessing the risk for AD. So the last thing that we now, I just talked about, but it was the result of many years of research is treatment, patient selection and tracking of treatment efficacy. I just described. You just do a amyloid PET, but these are a result of many years of research, and this is something new actually, which is both for individual patients for clinical trials, imaging has contributed in making this better. Maybe if you follow the news in the last 10 years, you probably have heard that a lot of trials of anti-amyloid therapy failed. In fact, kind of putting in doubt the whole kind of hypothesis of what causes AD. But we now know that that was because the patients that were recruited for these trials were not characterized very well. And imaging has helped to change that with characterizing them with amyloid, tau, neurodegeneration. So it has helped the trials in getting the patients which are most suited for the therapies that are being tested. Because in the past, maybe some patients had comorbidities, maybe they had too advanced of a disease. Right now, imaging can help narrow down the subject pool that's most appropriate for the medication that is being tested. You have evidence of whether somebody has amyloid or tau and at what extent, because amyloid can also be quantified, not just yes and no, but how much there is, specific number. And it turns out that these medications, the new medications, are most effective in folks with the lowest amount of amyloid. So, to test something like that, you need people who are in the, you need to know how much amyloid people have. So imaging helps in that. You can also track the changes, meaning you can track the effects of the medication by doing these PET scans. And yeah, you can focus on the stages where treatment is most effective. And imaging has really helped in elucidating the sequence of when these abnormalities appear. So this is a super famous graph that you've probably seen if you've listened to other lectures or you've perused the literature that shows when abnormalities appear in relation to the clinical symptoms. Clinical symptoms here start after these dotted lines. So the x-axis is time, and after the first dotted line, that would be the first signs of MCI, mild cognitive impairment. The second dotted line is the onset of dementia or Alzheimer's disease. So these lines are when these biomarkers become, when these abnormalities start and how much there is of them at each point. So, for example, the red line is A beta. This is amyloid. A beta means amyloid. You can see that accumulation of A beta starts way before somebody's MCI. And after that, so this is kind of the first event from these abnormalities. Second, you have tau. Tau accumulation also starts way before any clinical symptoms. This is the blue line. And the light green is the brain structure, which means atrophy. So this is the neurodegeneration, which is assessed by MRI. Starts last, really gets going in MCI. But you have amyloid, and that's why I showed you that amyloid is abnormal already before MCI. These are kind of the pictures I showed you, kind of showing the abnormalities. And here I'm plotting them in with respect to time. And you can see, the normal down there and the abnormal up, because the y-axis is how much of abnormality there is. So from normal to abnormal amyloid already in the preclinical stage. Tau gets accumulated in around the hippocampal area by the time of MCI, and then the atrophy follows. So imaging has obviously helped in elucidating these temporal dependencies. And they also kind of tell us about causality. I mean, this is not very, this is not clarified yet, but we kind of say that amyloid accumulation somehow triggers tau, and tau triggers cell death. And this is known as the amyloid cascade hypothesis. Once there's amyloid, then all these downstream events happen, culminating in neuronal loss, which is where then you have the symptoms of dementia. So imaging has helped in this regard. And big contribution of imaging has been in defining a biological definition of AD. Based on these biomarkers of A for amyloid deposition, of T for tau, and for N for neurodegeneration. And I presented to you how imaging is related to each of these markers, and imaging has helped define these designations. So subjects can be defined as positive or negative on each of these markers, and imaging can be used to define each of them. CSF plasma can also be used to define each of those, but they have their shortcomings. First of all, they're just one number, so you don't know where the accumulation of A beta or tau is. Of course, CSF, to get to the CSF, like I said, lumbar puncture is an invasive procedure. Plasma is something that's up and coming, and it's gonna become more dependable in the future. Right now, it's still in the testing phase, but it also doesn't have regional specificity, although it's not invasive. It's simple blood draw, so it has great potential to be a screening tool when it gets validated. But yes, you cannot actually, it's one number, you don't know where exactly the accumulations are happening. So interestingly, we have an updated framework of the biological definition of AD, which other than ATN, the amyloid, tau, and neurodegeneration, includes other processes that are deemed important in AD. And they are inflammation, vascular changes, and alpha-synuclein, or S. So IVS are new markers that are important in AD, which need to be quantified in some ways. And you can see the question marks there. That means there is no actual imaging marker for that. So this is a huge research direction in imaging of AD to be able to image inflammation, image alpha-synuclein. So alpha-synuclein, by the way, is another protein which gets accumulated. It's mostly accumulated in Lewy body dementia, but almost all AD patients also have some degree of alpha-synuclein accumulation. So it does play a role in AD as well. And researchers do want to take it into account in this definition of AD. So we need to find a way to image that, to measure it. Currently, you can measure it with CSF and plasma. Vascular, there is no vascular markers of, there is no plasma or CSF markers of vascular changes. But actually, MRI is very good at that. The images I showed you can detect, can show areas of microinfarcts and changes that are associated with vascular problems. So MRI, from the types of MRI I showed you in the beginning, can tell you about vascular changes. But like I said, the current research related to this updated biological definition of AD, which just came out last year, is related to measure inflammation, alpha-synuclein, but also PET imaging is used to validate these plasma markers. Like I said, plasma is an up-and-coming way of measuring amyloid and tau. It's not invasive. You don't need to do a PET, which does involve a radioactive tracer, but you need to validate these markers first, and you validate them with the gold standard, which is imaging. So a lot of work being done there. And I'm gonna finish with telling you about how imaging can tell us about brain abnormalities that are not related to ATN, the amyloid, tau, neurodegeneration, or even the new ones that are inflammation, vascular, and alpha-synuclein sorts of pathologies. Because there's other things that are important in AD that happen to the brain, other changes that we would like to measure. They can be a result of these central pathologies, they can be a result of amyloid, tau, or so forth, or they can be actually independent, just some sort of other changes that arise independently. We would like to be able to see them, to measure them. They will tell us about disease mechanisms, They can explain symptoms. They can identify therapy targets as well. So it's important to also look at other sorts of pathologies, other sorts of abnormalities that happen in the brain that don't have to do with the classic amyloid tau neurodegeneration framework. So for that, we turn to these sorts of other sorts of MRI that I touched upon in the beginning. That is not just the anatomy, looking at total brain tissue. And here we don't have time, and I will just go over one of those techniques for detecting different sorts of changes. MR spectroscopy, which detects changes in chemical concentrations. So this is what I'm working. This is kind of my main sort of concentration, to use MR spectroscopy to understand better other changes that are happening in AD. And MR spectroscopy works the following way. You get this sort of thing on the right, which is called a spectrum. These lines are called a spectrum, and these peaks correspond to the amount of chemicals there are in the brain. So you get this spectrum from a specific brain region, and you can see what chemicals there are there. And the amplitude of the line, how high the line is, or how much area there is inside this peak, tells you how much of the chemical there is. So you can quantify different chemicals in the brain using MR spectroscopy. And this is just using a regular MRI machine. It's just different way of using it. So these different peaks correspond to different chemicals in the brain, and each chemical can tell you about something about the brain. So this largest peak is the peak of a chemical called N-acetylaspartate, or NAA. It's a peak which is it's a chemical which is contained only in neurons, and its concentration is indicative of neuronal health. So the less NAA there is, the less well the neuron is doing. So basically, there's issues with the neurons if you see a lower NAA. So you can compare high to low, and you can see, you can say that the tissue, some tissue looks normal on MRI, but the neurons are actually not doing well. Their NAA peak is lower. That means there's underlying problems in the metabolism. And of course, any problem first becomes apparent in metabolism. Before the tissue starts to die, the chemistry changes inside the brain. First are the chemical changes, and then they cascade to something that causes death. So spectroscopy is really good at looking at these chemical changes, which can actually maybe tell you what will happen in the future. And we have these other markers that we can measure. Creatine, choline, you can measure a combination of glutamate and glutamine, something called myoinositol for astroglea, and we can measure the height of these peaks and therefore how much of these metabolites there are. And we can compare what we think would be normal levels to levels in folks with MCI or MD. And these are the sort of changes that we see. So we do see lower NAA, which speaks that there is some neuronal dysfunction in AD and before AD in MCI as well. We see higher myoinositol, which tells us that there is astrocytic activation, which is related to inflammation. So we have a marker for inflammation here, which is really, really nice to have. We also, however, there's good information in the metabolites that don't change. We know that there is no problem with the membrane turnover, for example. That's the cell membranes, they're doing well. There is a common finding is also lower glutamate, and that we think is related to the synapse loss that also occurs early in AD. But this is complementary information that can be used to tell you about different things that are happening, which can explain symptoms, which can explain disease mechanisms. So techniques that are not conventional MRI, such as MR spectroscopy, tell you additional information that could be useful in these regards. And this is the summary. So, why the topic of this talk was, importance of AD research, of AD imaging importance of imaging in AD research. And it has, enabled so many things in clinical care and in fundamental understanding of AD. I went over how imaging has changed diagnosis, prognosis, and treatment of AD. And in the last few slides, I talked about how imaging has clarified the progression of AD, what happens when, what precedes what, It can tell about disease mechanisms. It has helped define a biological definition of AD, which wasn't really the case, maybe 10, 15 years ago. And it quantifies brain changes that we don't really see with conventional imaging or even on gross examination ex vivo. So imaging has really contributed a huge part to AD research. And with that, I will close, and I'm happy to take questions.